More than 18,000 scientists, community leaders, civil society representatives, development partners and political leaders descended on Durban, South Africa for the 21st International AIDS Conference. At this high-level side meeting, political leaders, policymakers, community leaders, civil society and development partners met with one objective: to reduce new HIV infections in Eastern and Southern Africa from 910,000 in 2015 to 210,000 by 2020. The high-level meeting was co-hosted by Dr. David Paririnyatwa, Zimbabwean Minister of Health and Childcare, and Dorcas Machado, the Health Minister of Botswana. The Eastern and Southern Africa region has only 6.2% of the world's population, but is home to half of the world's people living with HIV. The region is the hardest hit by the AIDS epidemic.
On behalf of our UNFPA and the World Bank, I welcome you to this evening. We saw that there is an imbalance between now our treatment achievement, but between that and prevention. And we're saying, look, we know, for example, in our region, 90% of the mothers have access to services to prevent mother-to-child transmission. But the best way to prevent mother-to-child transmission is to prevent women from being infected in the first place. So hence we need, as the minister has always said, to close that tap and ensure that women are not infected in the first place.
It is an honor and privilege for me to be here tonight with you. Let me start by saying how much I appreciate the commitment of our Minister of Health from southern part of Africa. I think you're making a huge contribution to change the paradigm in prevention. Yes, new infections have come down. Let us not make any mistake. If you go to 90s and you come back to now, you will see that we came from maybe a 3 million new infection amongst adults, and we had a reduction by 35%. But if you look at the last 5 years and you take numbers of children, reduction among children, you will see that adult infection is stagnating or even increasing in some countries. And that is worrisome for me. It is a sign that if we don't pay attention to this prevention agenda, we will have a problem. And I talk about 1.9 million adults have become infected every year since 2000. Our prevention programs are not working at all for young women in sub-Saharan Africa. In some African countries, 25% of young women will become infected before they turn 25. That is just a huge number. You cannot really make a breakthrough in general and controlling epidemic if you have such of increased number. And also what is even scaring us is that 75%, so 3 out of 4 adolescents who are infected are girls. That is issues we need to pay attention to.
In Zimbabwe, we focused right early on from 2000 on the issues of prevention. We saw that in terms of HIV, we saw that prevention was key. And again, like I say, our strategies have always been those three: of prevention, prevention, and prevention. And we saw that the behavior of our people changed, because that's key to prevention, behavioral change. And we saw HIV steeply coming down from upward of 29%. Now it's about 14%.
There's biomedical prevention that runs within the Ministry of Health, and there are numbers that have to be achieved in terms of service delivery, whether it is uptake of condoms, VMMC, that is voluntary medical male circumcision, or PrEP. We have developed a fast-track plan to end adolescence and HIV that has targets, and those targets are assigned to specific government agencies. So for instance, the education sector has specific targets on teacher training by numbers that are actually assigned to them. And every 6 months, we are required to put together a report from those different agencies. So there's a certain level of these targets are not negotiable, they have to be met somehow.
Dr. Kilonzo says they are also targeting the faith sector to carry the message. They reach around 20 million, that is half of the population, every weekend.
We have asked them that once a quarter, that there is a HIV conversation in every single significant faith in our country, to discuss stigma and to discuss prevention. And that the last week before World AIDS Day, that whole week, we are asking every faith to dedicate it to matters HIV. We believe that if we do that, we'll be able to get the results we are looking for.
In Namibia, and that's why we are actually a number of us here in this audience, probably more than 10. And all of us are traditional leaders and healers. All of us are teachers. All of us are doctors. So we multitask. This is our resolution, actually, as far as we're concerned. So what am I saying here? It's a responsibility for all of us. We just had a meeting about an hour ago, actually, from Namibia, and we allocated tasks to each other to strengthen what we have initiated. I'm sitting next to me with the Deputy Minister of Education, and there are many from other ministries and NGOs here. We advocate and implement a comprehensive sexual education, reproductive sexual health in school, and I'm told it's from grade 2 or 4.
Grade 4.
Grade 4. So this, we believe, is the way to turn down the tap. Not only that, we want to intersect the determinants, the spread of the virus. We just heard what South Africa has presented on the phylogenetic of the disease transmission. And we think that we may actually be missing the one boat. While looking at truck drivers, sex workers, etc., we may miss the migrant workers because the contract system is still embedded within our labor system in the country. We're emphasizing on data capturing. We must keep knowing what is that we're doing. Are we doing it right? We, at least in Namibia, neglected the civil society in the prevention campaign. This is what we are revitalizing now, and we started already. Civil society involvement, for us, very, very crucial. As leaders in this part of the continent, adopt the Revitalising HIV combination prevention commitment. The first strategy we started off a long time ago is actually prevention campaign and information dissemination. Biomedical or treatment in hospital only started in 2003. Throughout the campaign was to prevent the transmission of the virus. So the attention literally shifted towards hospital-based treatment, and we sort of forgot about prevention. So roughly 9% is what was allocated to prevention. That's why I made it a point since I came in office last year that at least a minimum of 30% of our program budget will go to prevention.
In Namibia, they make use of celebrity figures, popular figures and champions to encourage voluntary medical male circumcision.
I do it myself, and we look for champions. We look for musicians, for instance, whom we know have got an attraction, and they're the one who deliver the message. I circumcised the most popular musician, and then he took me on the stage. This guy gave me a smart card. Guys, are you going for the smart card? Yeah, we go for the smart card.
Looking at prevention, you have repeated it 3 times. Prevention, prevention, prevention. With combination prevention, all work together. And if we are to invest in prevention, we need to invest in those things that are very tangible and will give us, results that are measurable. And if we begin from
the structural ones, if we can address the practices in society that predispose our people to infections or barriers that prevent uptake of HIV services, that would largely bring us to the point of prevention.
And we have certain tribes and cultures that favor child marriages. But we have been running a campaign against child marriages to try and sensitize the population to get to know the dangers of marrying off their daughters early, both psychologically, medically, and otherwise, because it traumatizes the child, and it also affects the development of the body of the child and lowers the self-esteem of the child, so that this child cannot develop to have full potential, ready to contribute to the economy of the country. We have the Constitution that spells out the age of marriage. But it would be good, of course, obviously, to have a specific law on child marriages. And from, the conversations we've been having in this conference and the importance of having a law, I think we are going to push for a law. We look at other methods of biomedical prevention, like the voluntary male circumcision, control of sexually transmitted infections, and majorly HIV testing and counseling.
And if we are looking at adolescents, we have been discussing this, and there is no way we can run away from the comprehensive sexuality education that must be, embraced in all our countries. But we also need to scale up adolescent-friendly services, whichever way we want it, but bring adolescents on board. I think we now need to spread out a lot more wider using the total market approach.
It's also very important to look at who do we target? Because there are people who are left behind, like street vendors. They are running their businesses, and in the informal sector, you cannot leave that place and go to a clinic. How do we support them? How do we go into the community using outreach services? Because we have to go to the community. Our clients don't live within hospitals and clinics, and it's not fair for them to be walking for 10, 20 kilometers. Index patients. If a mother who is HIV positive, let's go to the community to go and test the children in her family and people around that family. But to protect them from stigma, let's offer primary care services at outreach level. Let's go to the schools and prisons. You'll find people there. Men, the most difficult client on earth, a man, because they are quite scared of going to the clinic. They have to be guided by their wives. So let's have a family approach. What about our faith healers and our church leaders? Initiation schools. That's where the traditional initiation schools, our local African universities, how do those people there access, and the head boys? It's also important to start from scratch. Mothers, you cannot separate a mother from a child. If the mother is expecting a baby, what about PMTCT? What about offering those services? What about offering those services even when we go into the community?
We're also going to focus on internal migrants, especially young women who work in factories, because they are being ask for transactional sex while waiting for the job. They don't earn a lot of money. They are away from their villages where they have their social protection, and they are in town in Maseru. We also focus on people who work in South Africa. There's a lot of migration throughout SADC. We still have people who are fruit pickers in South Africa. We still have miners, and we are aware that people have concurrent multiple partners.
Dr. Monyamane says there is an urgent need to provide education to young girls and to keep them in school.
Also going to strengthen keeping the girl child at school. We have pre-primary education in Lesotho, but the poor and the vulnerable are unable to go through high school, so there should be cash transfers. 76% of people in Lesotho have cell phones. This is where a lot of young people are. We're going to use innovation and use technology to talk to them. The most important thing about leadership in Lesotho, we've just passed a law. So the bill was passed on the 14th of July for banning child marriages. We're going to strengthen the voluntary male circumcision, because so far 100,000 young men have been circumcised. But we would like to extend that to older men, from 24 to and older, and partner with the traditional healers who actually, and traditional leaders who actually manage or initiation schools.
Last year this time we were thinking of going along with what everyone else is doing, starting treatment on the basis of viral load and so forth, a CD4 cell count of about 500. That's what we were headed. And then we decided midstream to say it's not going to work for us. On the basis of science, on the basis of the figures that we had, we did a complete investment case for Botswana, where we had to look at the picture now, picture in 5 years, picture in 20 years, how much resourcing we had to put in, and what we're going to get as a return in investment. And the return in investment that we're looking for was for us to arrest the scourge of infection. And treat all seemed to be the best option for us, because as you know, if you go into treat all, or if you start treat all, you'll suppress your viral load to an extent that it becomes difficult to infect another person.
I have to acknowledge all the leaders from different governments sitting here today, not least my own minister from Namibia, Dr. Bernard Haufeku. My own Minister of Health in Namibia has really been at the forefront in so many ways when we deal with prevention. Our government has for the last 2 years been working on a combination prevention strategy. When combination prevention was no longer the flavor of the day, they ignored the advice and they persisted. And as I announced in this meeting, let us praise our Minister of Health for securing 30% of our HIV funds for prevention. That's major. The point is, we shouldn't be beholden. We shouldn't allow other governments or donors or interests to set our health priorities, because we are paying for our own responses, largely. We should be asking them to help where we feel the help is needed, where the data locally shows that we should be working. So I'm greatly relieved to see that we are coming to our senses and we are really truly taking ownership of our responses in our region. And we are calling on the development partners and the technical assistance to help us. So that's huge progress.
I believe we are in Botswana as traditional leaders, and I think we have been given the opportunity to showcase what traditional leaders and the communities can do, acting together. We really appreciate the opportunity that we've been given to showcase this and work hand in hand with other international partners to bring this or closing this tap that has been flowing for a long time. Thank you very much.
The number of new infections remain unacceptably high amongst adolescent girls and young women between the ages of 10 and 24 years, and their male sexual partners. In 2015, there were approximately 4,500 new infections per week amongst adolescent girls and young women, double that of boys and young men. Nokanya Yolwa explains that people are getting sexually active at a very young age.
young people are starting to engage in sexual practices very early. And roughly now we're looking at 9 years, 10 years. That's how bad it is now. And without parents involved, without parents being involved in discussing comprehensive sexual education for their kids, the HIV prevention won't go down.
Olwa says that youth should be engaged in all planning.
Young people are not involved in these issues on planning level and on implementation level. Young people need to be involved in innovation, new innovation strategies, and they must know what the government is doing for their prevention strategies. They need to be involved in those strategies. They need to be part of the discussions and the decision-making processes. They don't have an idea of what they're doing. There is no support from home. The parents don't talk about sex there. At schools, teachers don't talk more about sex and how young people can know and attract or get information on safe sexual practices.
Key populations such as sex workers, men who have sex with men, transgender people, and people who inject drugs, and prison inmates also experience high HIV prevalence. Caroline Njoroge is a sex worker representing Kenya's key affected Population Health and Legal Rights Alliance, and this year they won the 2016 Red Ribbon Award for their inspiring work towards ending or reducing the impact of the AIDS epidemic.
In Kenya, sex work is a crime, and we are also charged with loitering with an intention of soliciting sex. We still remain criminals. We are harassed, we face a lot of violence. We are arrested in possession of condoms, and recently, since last year, sex workers who are using PrEP, Truvada for prevention, have faced a lot of violence because many of the clients and security bouncers think that those drugs are used to spike clients' alcohol. Access to health services at times is very complicated in health, in government and public health settings. There is still a lot of stigma and discrimination that is leading so many sex workers not to access health services. Many are living under denial because they do not want to be gossiped around. For me as a sex worker, I feel that even though they speak in quotes about the key populations and sex workers, I feel that there is the big gap of inclusion, the meaningful engagement. I would like the government to give capacity to the community organization to strengthen our systems, capacity builders, so that we reach to the level that they want us to be able to be implementing our own programs. We only need to learn. Tell us what we are supposed to do, then we can do it better.
At this high-level meeting, development partners committed to support for the HIV prevention agenda.
So we're very happy to be here. We support all of the things that you have been talking about. And as you can tell from our investments, we are matching our words with our dollars as well. Looking at VMMC has been very key, and President Obama also announced high-level targets for this year and next year for male circumcision, and being able to look at the male partners of these adolescent girls and young women, get them onto treatment so that we're virally suppressing HIV, so we are breaking that cycle of transmission back to, and as we've heard in the plenaries, these cycles of transmission from young women to older men to their partners as well.
I would like just to highlight two perspectives, and one is all the countries here around the table, including with the support from ESC and SADC, as well as AU, can do with your own legal frameworks, and to facilitate how you reach people and how you don't discriminate people. Secondly, I want to just mention, don't forget, engage the boys and men.
We are partnering with UNFPA, UNAIDS, and UNESCO. And as you know, we are not a donor, we are an implementation agency, so I can just give you some of the targets our German government wants us to help, to contribute, to promote. One of them is ownership by a country. I was really so happy to hear the presentation from Kenya about the clear decision. In Kenya, we have only one data system and everybody has aligned to, and this is one of the ways to understand what is ownership in a country, because you need informed decisions at real time. I think we have heard about so many interesting models, and we should just partner together to promote them and to help a country to have those informed decisions, because this also promotes accountability which should start at a local level.
It is clear that if the ESA region is to achieve the goal of ending the AIDS epidemic by 2030, we must close the tap on new HIV infections. The first step is to ensure country ownership and political will, and actions to drive the HIV prevention agenda.
Clearly, political leadership at the highest level is critical, but that leadership should percolate right down to the villages.
I think there was clearly a sense that there are a multiple of broad-based stakeholders that need to come around, from religious leaders to young people to communities. And I think those partners, some of them need capacity. And I think there was a clear call, particularly for community-level capacity building, for young people's capacity, for other implementing partners' capacity. And so we will again help to build those capacities where they don't exist, but also to actually utilize capacities as well.
The 2016 Political Declaration on HIV and AIDS sets a regional target for the Eastern and Southern Africa region to reduce new HIV infections among young people and adults to 210,000 by 2020.
The problem that we are having is that new infections among young people are still going up, especially among young girls. They are 3 to 5 times more likely to be infected than their male counterparts. So we are really saying there's a gap in there. And we are not doing quite as well as we are doing with ARV promotion and, mother-to-child transmission. So it's a gap that we want to ensure that we fill, and the time to fill it is now. Prevention is a multi-sectoral approach, and we have to have a multi-pronged approach to it in order to really ensure that it works. And I think with what we are doing now, as long as we monitor and show successes and the challenges, we will be able to get there and be an example to other regions. And we know with that we can really say, yes, we will be able to reach the end of AIDS as a public health threat by the year 2030.
Ending the AIDS epidemic as a public health threat by 2030 is within our reach if we fast-track the response. This can be achieved through embracing the target to reduce new HIV infections globally to fewer than 500,000 by 2020, and increasing and front-loading investments. To contribute to this global target, the ESA region should work towards its regional target to reduce new HIV infections to fewer than 210,000, a 75% reduction by 2020. To attain this regional target, a paradigm shift with renewed commitment and accountability in the HIV prevention response by countries is crucial.
We don't want to simplify. We don't want to complicate either. But we also cannot wait until it is too late. We need the drugs. We need the money too. We need 10 conversations if we are to end AIDS. Conversations from you.